Frances's sister called on a Tuesday afternoon. She had just come back from a urology appointment. She'd been having bladder problems for about a year, frequency, urgency, waking twice in the night, and her urologist had given her a prescription. She was 66 years old. The prescription was for oxybutynin. "Is that a good one?" her sister asked Frances. Frances, the retired nurse, who we last met in the 6th video of this series, when a gastroenterologist reviewed her pie prescription and started a process of rebuilding what 7 years of acid reflux medication had quietly taken from her gut, Frances paused. She knew oxybutynin. She had been a nurse for 30 years. She had seen it prescribed. She had never thought to question it. And then she had gone through her own medication review, and she had started reading everything she could find about drug effects in older adults, and she now knew something her sister's urologist had not said. She said, "I think you should ask some questions before you fill that." I'm Dr. Ben, and this video is about the medication that appears on more women's prescription lists than almost any other drug discussed in this series prescribed for a real and often distressing condition, by physicians who are following standard protocol and that carries the highest possible anticholinergic burden score while being routinely dispensed without the cognitive risk conversation that the guidelines now explicitly require. Because the 2024 guidelines have changed, the conversation is now required. And most patients are still not having it. Let me start with what oxybutynin is and why it is so widely prescribed. Overactive bladder, the condition oxybutynin treats, affects an estimated 33% of men and 40% of women over 65 in the United States. It is not trivial. Urinary urgency, frequency, and nocturia, waking at night to urinate, disrupt sleep, limit social activity, and cause significant anxiety and quality of life impairment. It is a real condition that deserves real treatment. Oxybutynin has been a first-line treatment for overactive bladder for decades. It works by blocking muscarinic receptors in the bladder wall, reducing involuntary contractions. It is effective. It is generic. It is inexpensive. And it accounts for more than half of all overactive bladder medication prescriptions in the United States, despite significant and growing evidence that it carries cognitive risks that its alternatives do not share to the same degree. The mechanism of that cognitive risk is the part Frances had researched after her own medication review, the part that, when she explained it to her sister on that Tuesday afternoon, made her sister go very quiet. Oxybutynin is not merely a bladder-selective muscarinic blocker. Muscarinic receptors are distributed throughout the body and throughout the brain. Oxybutynin blocks them system-wide, including in the hippocampus, the region of the brain most responsible for forming and storing memories, including in the frontal cortex, which governs attention, planning, and executive function, including in the cholinergic pathways that Alzheimer's disease attacks first. On the anticholinergic cognitive burden scale, oxybutynin carries a score of 3, the maximum, the same score as amitriptyline, the tricyclic antidepressant, the same score that, in Margaret's medication list in our 12th episode, contributed most heavily to a combined burden of 9. And yet oxybutynin still accounts for more than half of all overactive bladder prescriptions. In a population of patients who are, by definition, older adults with reduced acetylcholine reserves, reduced cerebral blood flow, and reduced cognitive resilience. Now let me give you the research, because this is not a theoretical concern. A 2024 study published in BMJ Medicine examining 170,742 patients aged 55 and older in England found that use of any anticholinergic medication for overactive bladder was associated with a significantly increased risk of dementia. The adjusted odds ratio was 1.18. And the analysis specifically included oxybutynin among the drugs driving that association. Frances could have cited this study to her sister. She didn't need to. The mechanism had been enough. A meta-analysis of 11 cohort studies and 3 case control studies found that antimuscarinic medications were associated with increased risk of all-cause dementia and Alzheimer's disease. And in clinical trials specifically testing cognitive function in healthy elderly people without any pre-existing cognitive diagnosis, oxybutynin has clearly shown adverse effects on cognition. Memory tests, attention tests, processing speed. The 2024 American Urological Association and Society of Urodynamics guidelines updated specifically because of this accumulating evidence now explicitly state that clinicians must discuss the potential risk for developing dementia and cognitive impairment with patients taking or being prescribed antimuscarinic medications like oxybutynin. That is a formal guideline requirement. The conversation is now mandated. Francis's sister had not had that conversation. Now let me be precise about the evidence, as this channel always is. Not every study has found significant cognitive impairment from overactive bladder antimuscarinics. A 2022 retrospective cohort study using National Alzheimer's Coordinating Center data matching 782 pairs of OAB anticholinergic users and non-users found no statistically significant increase in clinically relevant cognitive decline among OAB anticholinergic users overall. However, users of oxybutynin or tolterodine specifically had numerically higher odds of cognitive decline on the CDR instrument close to but not reaching statistical significance. The evidence is not uniform, but it is consistent in its direction, and oxybutynin is consistently identified as the highest risk agent within the class, with the strongest human evidence for adverse cognitive effects. What makes this situation different from most of the medication discussions in this series is that there is now a well-studied, widely available, non-anticholinergic alternative. Mirabegron. Mirabegron is a beta-3 adrenergic agonist, a completely different mechanism from oxybutynin. It relaxes the bladder wall through a pathway that does not involve muscarinic receptors. It carries no anticholinergic burden. Its ACB score is 0. And multiple clinical trials have demonstrated equivalent or near equivalent efficacy to oxybutynin for reducing overactive bladder symptoms. A systematic review and meta-analysis published in 2021 in European Urology found that mirabegron had comparable efficacy to antimuscarinic agents for OAB treatment. The 2024 AWA/SUFU guideline update now positions mirabegron alongside antimuscarinics as an equivalent first-line option, and specifically notes that mirabegron should be preferred in older adults given the cognitive risk profile of anticholinergics. The drug exists. It is approved. It is covered by most insurance plans, and most women over 60 being newly prescribed oxybutynin are not being told about it. Frances told her sister all of this, carefully, without alarming her, without telling her to ignore her urologist. She said, "You have a real condition, and it deserves treatment. But before you fill that prescription, I want you to ask your urologist one question." Her sister called the urology practice the next morning. She spoke to a nurse practitioner, explained that she had read about the cognitive risk profile of oxybutynin, and asked whether mirabegron would be appropriate for her situation. The nurse practitioner said yes, and switched the prescription without requiring another appointment. One phone call, one question, a completely different cognitive risk profile. Frances's sister called Frances back that afternoon. "You probably just saved my brain," she said. Frances said, "You saved your brain. You made the call. Now what should you do if you or someone you love is currently taking oxybutynin or has just been prescribed it?" The first thing, do not stop abruptly. Frances's sister didn't stop, she switched, with the prescriber's full involvement. Any transition from oxybutynin to mirabegron should be discussed with and managed by the prescribing physician or a urologist. Stopping oxybutynin abruptly can cause a rapid return of overactive bladder symptoms. The goal is a managed switch, not a unilateral decision. The second thing, know that the switch conversation is now guideline supported. The nurse practitioner who answered Frances's sister's call knew exactly what she was asking, because the 2024 OA/SUFU guidelines had already positioned this as a required clinical discussion. You are not raising a concern that falls outside standard care. You are asking your physician to have a conversation that the guidelines now mandate. Most physicians who know the guideline will welcome the question. The third thing, if you are currently on oxybutynin and have been experiencing brain fog, word-finding difficulties, or memory changes, add oxybutynin specifically to your anticholinergic burden review. Because oxybutynin at a score of 3 is the single highest rated drug on the ACB scale in routine clinical use for this population. Even alone, it exceeds the threshold associated with cognitive effects. In combination with other anticholinergic drugs, a sleep aid, an antihistamine, an antidepressant, its contribution to a combined burden score can be substantial. Here is the question to bring to your urologist or primary care physician. I've read that oxybutynin has the highest anticholinergic burden score among overactive bladder medications, and that the 2024 AWA guidelines now require discussion of dementia and cognitive impairment risk with patients prescribed antimuscarinics. Given my age and cognitive health profile, would mirabegron be an appropriate alternative for my condition? And if I'm on any other medications with anticholinergic properties, I'd like to understand my combined anticholinergic burden. That question cites the specific guideline. It names the specific alternative. And it connects the bladder drug to the wider anticholinergic picture, making it a whole medication list conversation rather than a single drug question. Francis's sister is now on mirabegron. Her bladder symptoms are managed. Her ACB score is 0. She told Francis something that Francis told me. She said, the urologist was completely focused on my bladder. It never occurred to him to think about my brain. That's not a criticism of him. It's just how the system works, one organ at a time. One organ at a time. That is the gap this channel exists to bridge. In the next video, I want to cover a topic that connects to every pillar of this series, the role of chronic stress in accelerating brain aging after 60. Because cortisol, the stress hormone that rises in response to late eating, poor sleep, and circadian misalignment, has a long-term relationship with the hippocampus that explains some of what looks like inevitable age-related memory loss. And it may explain why some people age cognitively faster than others under objectively similar health conditions. Subscribe so you don't miss it. And if you know a woman over 60 on oxybutynin who has never been told about mirabegron or about the cognitive risk conversation her prescriber is now required to have, share this with her. One phone call. One question. A different prescription. I'm Dr. Ben. I'll see you in the next one. The information in this video is for educational purposes only and does not constitute medical advice. Never stop or change a bladder medication or any other prescription without consulting your doctor. Always speak with your physician or urologist before making any changes to your treatment plan.